Thank you, Wim, for the introduction, and I also want to thank Jelle for his nice presentation and giving me the time to present my presentation in 5 minutes, because most likely active surveillance will die if we only do target biopsies. So in the next 20-25 minutes I will discuss the role of MRI in active surveillance. I have no financial disclosures. As mentioned before, prostate cancer, of course, the second leading cause of the cancer-related death worldwide. And also the incidence will increase, I think will be doubled in 2030, and that's mainly because of the aging global population. Also a little bit touched on before, but I think to repeat, PSA test, most likely drawn by the GP, general practitioner, or by the urologist. And when the PSA is elevated, the patient goes for a trust-guided biopsy. That's a standard paradigm. And 10 to 12 cores are being taken out of the prostate, and based on that you have the diagnosis. Are they significant? So patient goes for active treatment, and that can range from active surveillance to radical prostatectomy. Insignificant cancers, so Gleason 6 or Gleason 5s, or high-grade PIN and normal lesions, patients are sent back to the GP, and PSA will be repeated after a year. So some words on PSA screening. PSA screening results in overdiagnosis of prostate cancer, and as a result also an overtreatment. In 2012 the US Preventive Task Force looked into the PSA screening, and they recommended against PSA screening because simply, as mentioned before, if you do take the PSA sample, most likely if you find insignificant cancer, you will harm the patient. So, and also if you look into the details, if you look at the PSA screen detected cancers, they have a substantially higher likelihood to be less aggressive, indolent, and these tumors show both lower grade and lower volume disease at the presentation. So most likely the patient will not die from this disease. As mentioned before, the risk of diagnosis results in overtreatment. So in other words, if we go back 3 years ago, and there was a nice paper in the Journal of Medicine, it was shown that 50% of patients who go for radical prostatectomy will not benefit from this treatment. So there's really overtreatment. And if you look at the screening population, we need 48 males to be treated to save one life. If you compare it with breast cancer screening, it's a very unfair comparison, because then in those cases, you only need 3 women to be operated to save one life. So I'm not sure if screening is really helpful. Approximately 60% of patients who go for that radical treatment will have a form of rectal dysfunction, and up to 30% of the patients also have a form of urinary incontinence. Luckily not severe urinary incontinence, but a form of urinary incontinence is most likely will be present. So therefore, especially in the low-risk patients, active surveillance is emerging. So active surveillance is actually the strategy for reducing overtreatment, and it's actually a management option. So it's on the one side of the spectrum you do active surveillance, and the other side of the spectrum is active treatment, like radical prostatectomy or radiation therapy. And it's a management option for men with localized cancer who are fit for curative treatment. And it also should be that you have, if you select men at low risk of harm without treatment. So in other words, if you select those men and you postpone the treatment as long as possible, you will not harm that patient. And if you look in the literature, there are several groups in the world who are working and have a large population of active surveillance patients, and they all talk about low risk and very low risk, and I will come to that in one of my next slides. And approximately 1 out of 3 patients who opt for active surveillance will progress to active treatment within 2.5 years. And that's based on a 12-core biopsy. If you do a target biopsy, that will be different. So what is active surveillance? Active surveillance is actively monitoring the disease with the expectation to intervene with intent to cure only if essential. And that's based on the belief that if appropriate triggers, so if you have, for example, an MR, which you see progression in MR, if the PSA is doubled within 3 years, for intervention are identified. So we need certain triggers for this patient group to say, if the PSA density is doubled within 3 years, we have to do active treatment. Also, part of the Jurgen guidelines we see that an accepted form of treatment for low-risk cancer, access surveillance, be admitted. However, as mentioned also by the previous speaker, one of the barriers to widespread acceptance of active surveillance is for men with prostate cancer is the risk of underestimating the extent of cancer and missing the opportunity for cure. So we have to find those significant cancers and to rule out those insignificant ones. And that's also difficult because if you look now at the active surveillance group, it's based on a 12-core biopsy, and based on that, treatment decision is being made. And we also know that if you do a trust-guided biopsy, in around 40% of the cases, you will miss the cancer, will basically not see the cancer. And if you hit it, in 40% of cases, it's an indolent disease. So the patient will not benefit from this biopsy. And in the other 40%, if you find a lesion, most likely you will have a more aggressive one. An example, this is a very difficult case, a lot of BPH nodules in the transition zone. The peripheral zone is really compressed. It's quite hard to see, but in the 65-year-old male, PSA was only 4.5, Gleason 6 on the TRUST 12-core biopsy, less than 2% of the core was positive in the peripheral zone on the right side. And I don't see it on this image. Also in the diffusion and also the perfusion doesn't show any abnormality in the peripheral zone. And this is a quite common finding. In around 30% of the cases, you will not see a lesion within the peripheral zone if it was found on the TRUST biopsy. Another example, this was a patient with a PSA of almost 10, Gleason 6 on the left side, and we can clearly see that this lesion here on the left side with some unimpeded diffusion, but the high B value doesn't show you really high signal, which you would expect with a Gleason 7 or higher. So most likely this will represent a cancer. However, if we look closely to this image, then most likely we'll see a second lesion, and the second lesion is located over here. This lenticular shaped lesion, which clearly shows impeded diffusion and high signal intensity, high B value, and this is most likely to be a Gleason 7 or higher. So imaging helps you to find those patients who are opting for active surveillance, and turns out that you cannot, that the patient cannot go for active surveillance because the patient has a Gleason 7 or higher. And this is also one of the reasons, if you stick in a needle, then most likely you will sample this part up to the 1.7 centimeter line. And beyond that, you really have to perform target biopsy to find those lesions. This is a nice table with an overview on the several groups globally. And if you look at the entrance criteria for active surveillance, it's an interesting table, because if you look at the PRIOS, the European randomized study, let's see Gleason 6 or lower, the Hopkins Gleason 6 or lower, MSKCC 6, or a Martian 7 or lower, and then there's only not a dominant or predominant 4. Toronto, also 3+4, and the other groups still at Gleason 6. So it's very difficult if you want to compare those results between the group. They're very difficult because it's heterogeneous. You have heterogeneity between the groups, and it makes it difficult. Also, if you look at the tumor volume, there are several definitions and different definitions for tumor volume and for inclusion. If you look, for example, at the UCSF, at the Hopkins, it's two cores or less, and less than 50%. So there are strict Epstein criteria for inclusion. So these are the very low risk patients. I will come to the outcome for those patients in the next slides. Also, the surveillance approach is different, and that makes life also a little bit difficult. If you look at the group from Larry Klotz in Toronto, they do a rebiopsy after the initial biopsy between 6 to 12 months, and then every 2 to 5 years. PRIOS, 1, 2, and 7 years after the initial biopsy, and Hopkins every year biopsy. So I think imaging could play a role to get rid of, for example, the first biopsy set after 12 months, because it's very unlikely that the disease will progress within 1 year. PSA is also a little bit heterogeneous, but this is important triggers. So what is a trigger to go for active treatment? So going for a radical prostatectomy. And all the studies, they use a PSA density, PSA doubling time within 3 years. Pathology progression is also a trigger for all studies. And the price is a Gleason 6, is a Gleason higher than 6 or 2 positive cores. If you have that, then you go for active treatment. And peroneal invasion, that's specific for Hopkins. If you look more closer to the larger group, so the Toronto group and the Hopkins group, and if you look at the eligibility, 50% of the patients will be eligible because a Gleason 4+3 is also included in the inclusion criteria for active surveillance. And that's completely different from the Hopkins group. They only use a Gleason 3+3. And therefore the eligibility is only 20%. However, on the other side of the medallion is that you only have a 0.5 mortality, prostate cancer-related death. So if you have this, you can be quite sure that you will not die from prostate cancer. Whereas if you look at the Toronto group, it's a little bit more liberal for the inclusion criteria. But if you have a Gleason 7, there's a mortality of around 5%, a prostate cancer-related mortality of 5%. So in other words, as also mentioned by Jelle, what is the predominant or dominant Gleason 4 component in the biopsy result? So that's also one of the things we have to look into, but also genomics, I think, is very important to predict which patient is eligible for active surveillance. If you look at the prostate cancer-related survival at 15 years in 1,000 patients, active surveillance is 94.3%. In the Toronto group, in Johns Hopkins, is 99.5%, very high, compared to watchful waiting, it's around 89%. Time to intervention, that's I think also important, because some patients, they prefer to prolong the active treatment as long as possible, but you have also patients who prefer to get rid of the cancer because they don't like the idea of having cancer. But then around 55% will be untreated after initial diagnosis. So 55% will not be operated. They will still stick to the active surveillance after 15 years, and that's a high number. If you look more closely to the Gleason 7 cancers and the PSA level above 10, there's a clear distinction between the survival rate. So in the 93% of the patients who have a PSA above 10 will survive. Whereas if you have a Gleason 7, if the metastasis-free survival will be 77%. So it's also predicted. We also know if you have a Gleason 6 cancer, the likelihood that you will have metastasis is almost 0%. There's a group from Johns Hopkins again. They did active surveillance in 1,300 patients from 1995. And if you look at the overall survival, after 15 years, it's 70%. The cancer-specific survival is, however, it's almost 100%. And the metastatic-specific survival is also 99.4%. So based on this, you can conclude the Gleason 6 cancer you will not die from. Cumulative incidence of curative intervention at 15 years is 57%. So it's a little bit higher compared to the Toronto group. So how can we use mpMRI in active surveillance? For selection, of course, we want a reduction of the grade misclassification. We know on the initial biopsy, there's a misclassification rate in the order of 20 to 30%. Several studies have shown that. Also, the sidearm of the prior study has shown that 29% of the patients have actually a higher Gleason grade than seen on the initial trust biopsy. And re-biopsy results lead to an upgrading to 27% of the cancers, of the patients. And also, if you combine the mpMRI together with a targeted biopsy, then you can you have a much higher sensitivity for finding that high-grade cancer as compared to the blind biopsy. This is a nice paper in which they looked what's the impact of using MRI in the selection of patients for active surveillance. And it's just a summary, so small group, 16 men, suitable for active surveillance based on the biopsy. They underwent mpMRI and the biopsy within 1 year. And what they found that if you have a negative MRI in 38% of this patient group, only 2% were reclassified. Whereas if you have 40% of the lesions visible less than 1 centimeter, 11% were reclassified. However, if you have a large lesion, more than 1 centimeter, 18% of the patients were reclassified to a higher stage. So in other words, again, around 30% of the patients will be reclassified based on the MRI, whereas only 2% with a negative MRI was reclassified. Again, it's all about experience of the reader, of course. So, the other role of mpMRI in active surveillance is the monitoring, so reduction of surveillance biopsies, because I think that's really helpful. A lot of biopsies are taken, and I'm pretty sure that a lot of biopsies shouldn't be taken. So we want to avoid the routine one-year follow-up MRI of biopsies in patients with MRI stable disease. But the problem is, what is MRI stable? We don't have clear definitions of what is MRI stable. Is it based on the ADC value? Is it based on the anatomy of the lesion? Is a lesion size? Is that essential? We don't know yet. That's still some work for us to do. mpMRI also for sure has also a high NPV for reclassifications. For example, if you have a PARS 1 or 2 lesion, most likely PARS 2, the NPV is 100%, so you most likely will not upstage that patient. If you have a PARS 3 or 4, it's around 82%. So if you look at the guidelines, globally there are several guidelines. For example, if you look at the HCR appropriateness criteria in 2013, mpMRI may be appropriate for active surveillance, so for selecting patients. Whereas in Ontario, the mpMRI can be considered when a patient's clinical findings are discordant with the pathological findings. The NCCN in 2016, you can consider mpMRI if it's anteriorly located or if an aggressive cancer is expected, so that's still very vague. But I think with the NICE criteria, they already recommend to use it at enrollment for active surveillance, or even suggesting to use it for progression, to find if there's a progression of the disease. This is a nice case I got from Zoom Hader. 0 months inclusion, the PSA was 2.33, Gleason 6, less than 5%. 18 months, PSA goes up a little bit, but I think still within the error range. But after 25 months, PSA goes up to 4. So something is changing here. And if you look closely, something is growing here, isn't it? Gleason 8 on the biopsy, patient went for radical prostatectomy, and the final pathology score was a Gleason 7. So there's a moment in time that there is something changing, and the PSA is one of the markers which can be used to find out. MR visible lesion, I think there's also a discussion point. A large bulky tumor already, also high on the IB value. PSA 13, and the question is, of course, should we include this kind of patients in active surveillance? After 29 months, the PSA doubled, and that's also a trigger point, because PSA doubling time is a trigger point. It's almost 26, target biopsy, Gleason 8, 90% was cancer. So again, the key challenge is to define what constitutes radiological progression on MRI. I think that's still difficult. So to conclude, I think mpMRI can be very helpful for selection for patients for active surveillance, also for follow-up after a year or after 2 years to rule out significant cancers. But I think there are still some challenging questions which should be answered. What about patients with a Gleason 6 and MRI visible lesion larger than 1 centimeter? All those studies are being performed on 12 core biopsies, and I think if you see such a lesion, I would go for a target biopsy. Should MRI be used as a trigger for biopsy or for treatment in men on active surveillance? So then we need some criteria. What is disease progression? And is systematic biopsy still required if the MRI is negative? I think based on the literature, I think we can be quite sure if you don't see any disease progression, we should not use the biopsy needle. What's the follow-up interval? Most likely is not 1 or 2 years, more towards a 3 or 4 years follow-up strategy. And also the role of other biomarkers can be quite helpful, I think, in the selection of patients. And with that, I want to thank you for your attention.